The retina is just an amazing tissue, and compared to all the other tissues of the body, it uses up more oxygen per milligram than anywhere else. And most of that oxygen is to feed the rather greedy photoreceptors who just sump up oxygen. And to supply them, you have the choroid. And the choroid is the fastest circulation in the body. But even that is not enough. On top of that, it needs extra supply from the retinal vessels in the inner retina. It's in the normal day, it's only a small percentage that comes from the inner retina. But at night, the rods use even more oxygen. They gobble up oxygen. As it gets darker, they gobble up more and more oxygen. And when you're dark adapted, then it uses up the most oxygen. At that point, the inner retina has to supply even more oxygen to the outer retina because the choroid, strangely enough, slows down. It sounds anomalous, but that's the way the system works. And the disadvantage is that in the dark adapted eye, the inner retinal circulation can barely cope with what it's supposed to do in the normal eye. So you can imagine in the diabetic eye, where the inner retinal vessels are diseased and not functioning very well, we have real trouble and produce hypoxia. Well, in the modern world, we don't dark adapt very much because we have lights everywhere. Our ancestors had to navigate by starlight, and they were virtually dark adapted at night time. But we have artificial light, and so we don't dark adapt very often. The one time we do dark adapt, of course, is when we're asleep. What happens is with hyperglycemia, you get pathology developing in the retinal blood vessels. The vessels start to thicken their basement membranes. They lose pericytes. And they become sluggish. They swell in parts and form things called aneurysms that we're all aware of. And basically, they don't function very well. So the tissue around about them becomes hypoxic. And if you think of the inner retina suffering during the day, it gets even worse at night because of that high oxygen demand from the rods that has to be supplied by the inner retina, supplementing the reduced load of the choroid. So this is a real problem that is exacerbating the progress of the disease. And of course, as the disease progresses, you can get DME developing, and you can progress through from, with loss of vision, from mild, moderate to severe non-proliferative disease, and then reaching PDR, which is the proliferative part of the disease. Diabetic retinopathy ultimately is a blinding disease, if not controlled. Noctura 400 is a mask, a light mask that you wear at night, and it shines a gentle green light into your eyes. It's made up of a mask structure plus a pod with two OLEDs in it. OLEDs are organic LEDs. And The pod also is quite clever in that it monitors contact with the face, so you know how much mask wear that your patient has had. And this gentle glowing light is not really obtrusive. It goes through the lids and is of sufficient intensity to prevent the rods from dark adapting, but isn't sufficient to disturb your sleep too much. And in fact, after a few moments, because of the Troxler effect, you're not aware of it. The pod is fired by a battery that has a 3-month life. And by wearing this each night, you have effectively a home treatment for your patient. It's actually not a light treatment as such. What we're doing with the light is preventing those rods dark adapting and using the maximum amount of oxygen so that it relieves the stresses and strains and the hypoxia in the inner retina where the blood vessels are damaged. So the light, in a sense, is providing an indirect oxygen therapy. At this stage, we don't know exactly where mask intervention is most effective. We just have not got that data available to us. But we know that the mask has got efficacy. What is exciting, really, and what we have growing confidence about, is that we know that elimination or reduction of hypoxia is important at many stages of the development of this dreadful retinal disease. We know that it's a driver for late-stage disease, and we know that it's a driver for DME, the maculopathy. We also know that it's important in early-stage disease. So, because Noctura 400 has a very good safety profile, it has a potential to be used at many different stages. So that's the exciting thing about the mask. It's a home use device. And if the patient doesn't wear the mask, it doesn't matter how good a therapy it is, it's not going to work for them. And for some patients, that is the case. They find very early on that they won't wear the mask. But fortunately, that is by far the minority. And in all our studies so far, we now have experience of many hundreds of thousands of mask wear hours. It really depends how you define significant results. If you mean by significant results visual improvement, then the answer is very simple. Yes, you go for DME. And we have, from our preliminary studies, encouraging evidence that the mask will cause macular cysts either to go away or reduce in size significantly. And you can see evidence for that in the paper published in Eye by our group. In addition, in the Czech study, for example, there was evidence of visual improvement, albeit in a small group of 35 patients. So clearly, if you want to look for visual improvement by the mask, then direct it towards your DME patients. If you want cessation or improvement in terms of DR, then that's more difficult. But nonetheless, we believe because it's a treatment of hypoxia, that will work also. So we're not excluding any stage or in the progress on the life history of this disease. And in fact, with the Czech study, many of our patients had severe non-proliferative or proliferative disease. So we're really encouraged by the spectrum of use of this safe treatment. Certainly, if a patient has serious sleep problems that need medication, not self-medication, but they've seen their general practitioner, and a practitioner is helping them with sleep tablets, then I think mask wear should be discouraged. The other one is infections and severe corneal surface disease. I wouldn't want to be wearing a mask, and certainly if they developed an infectious conjunctivitis or keratitis or whatever, you would want to replace the mask material when that clears up. What a lot of eye doctors ask us is, we will stop using the mask because the media is cloudy, whether it be cataract or hemorrhage. I would continue with those patients as long as the patient's happy to wear the mask, and you've explained to the patient that there will be less light reaching the retina. Now, the reason that I think it's still worthwhile continuing is that any light reaching the retina will prevent a level of dark adaptation. It's not a light therapy, which I keep harping back to, it's an oxygen therapy. So the light is doing an indirect job for us. So there isn't a maximum or optimum light that we need. I look at it on the basis of the rod's role in life. And in our modern world, as I've said before, it's our cones that dominate what we use. Yet, anomalously, it's the rods that use up all this oxygen. So actually, if we think about a slight reduction in rod responsiveness, then it's probably a price worth paying. I think what worried us much more than losing a little bit of rod sensitivity was if it interfered with retinal pigment epithelial phagocytosis. And that, of course, as you know, is the process whereby the pigment epithelium chew off all the spent rod outer segments. And the cue for doing that is you waking up in the morning. That is a light stimulus. And of course, light off, light on is no longer really happening in our mask-wearing patients. But we needn't have worried because we've been assured by experts in circadian rhythm, and there's plenty of evidence out there in the literature that circadian processes like retinal pigment epithelial phagocytosis of rods can use many other signals. And in fact, that's what happens with night workers and all sorts of people who have an irregular light experience. This is very newsworthy at the moment because there are all sorts of press publications and scientific publications suggesting that exposure to blue light, which you can get quite intensely from your computer or tablet screen, will disrupt your melatonin release and affect your sleep pattern, and that seems to be quite sound. With the OLEDs in the light mask in Noctura 400, the wavelength is very tight, around 504 nanometers. So this is very much in the green. So I think it's actually less than 5% actually strays into the top end of the blue spectrum, and none of it, or minuscule amounts, are at the level that would affect melatonin receptors. The Liverpool trial was for 3 months and involved normal and patients with DME. And the Prague one was 6 months, and all the patients had DME and advanced DR. The Liverpool trial, albeit with small numbers, showed a clear reduction in macular thickness and a 60 to 70% reduction of cysts, or elimination or reduced size. So we were very impressed with that, because another group had showed a similar situation with resolution of cysts in their paper. So we are confident that this is something that our mask will do, and it will reduce macular thickening, and is particularly effective on the cystoidal type of DME. In the Prague study, 35 patients completed the 6 months, and we've been able to show at trial conclusion that there was a significant improvement in the completing group of their visual acuity, which is a difficult parameter to use even in a phase 3 trial. So that in a phase 2 trial, 1-2 trial, we could show this. It's really exciting. So we have, through these studies, been able to show that people will wear the mask, it's safe, and our device is CE marked, so we've been able to show levels of efficacy as well. I'm truly excited about Noctura 400. It's a clever device. It uses a novel mechanism to fight hypoxia, which is such a desperate driver for diabetic retinal disease. It has smart technology in it. It tells us whether the patient is wearing the device or not, and can be used at home, and so the diabetic patient is empowered in their own personal treatment. It's also a reassurance with that technology, because It tells you that they're using the device properly, and you can embed that into their treatment. But I think the thing that that excites me most is that this device does not break the bank in terms of cost. We need treatments that are cost effective and can treat the whole range of the disease as we see it. Thank you.